You can have it. All yours, Mike.
Yeah, that's your third, isn't it, Amanda? Good. I think we're probably good to get started, eh, Shane?
Yeah, I think so. Yep.
Okay, every meeting we kind of mention the schedule, so this is the same as any other. So as everybody knows, obviously May's out because we're in May. It's a silly thing for me to say, but we still do have a few open shifts left for May, including the Victoria Day weekend. However, when I originally made the slides, it said we have a lot of shifts open left for May, especially the weekend, and you guys have really come together and filled quite a few of them. You guys have been really good about moving shifts around, so I really do appreciate it. The Sunday, the 21st, I think we have a couple 12 to 3s and 3s to 6s. If anybody's feeling adventurous, we could get that filled up. And then there's some random kind of shifts here and there throughout the month. Lindsay and myself are taking some much deserved, I think, time off. So there are still a couple of our shifts just open, just to kind of fill in. Same with Amanda's taking a couple days off. So just have a peek through May and see if you can claim any more. And please continue to give us updates of any times you will be unavailable. Even if you don't have a recurring shift, what we've decided to do now is just kind of keep track of all of them, so that if we are short on a weekend, I'm not bothering people who are not available. Okay. And just send those to the scheduled email. And this has been a bit of a long running thing that we've been working on, but we now have our list of mentors. So sorry if you sent me that you want to be one a while ago. I was just trying to compile more than a couple. So here are our mentors. We've got Lisa, Melissa C, Jackie D, Jess C, Dawn, Dana, and Shauna. I mean, if you've worked with us long enough, you probably know these ladies are always willing to help out and know the system pretty darn well. So I am going to post this somewhere in Spot. I might have to get Mike to decide where we can post it. Just it would be nice to be in the workspace. I can have it in Slack too, but wouldn't be a bad idea to have it on the wall. So anytime you have a question or something during shift, definitely reach out to any of these girls. If I'm on shift, obviously you can reach out to myself too, but these guys will be helpful for the weekends for sure.
I thought the expectation was that they'd be in Spot 24/7.
No, that's you.
Yeah, we'll find a good spot to post them.
Okay, sounds good.
Oh yeah, I can handle this one. Unless you want to, Amy, you're here. Oh, maybe you're not.
I'm here.
Okay.
Sorry. I don't even have this slide deck open. Sorry, guys.
Okay.
I just wanted to let everybody know about payroll. Our bookkeeper David is going on vacation. Lucky David, and usually he would complete payroll at the beginning of next week, and he will be away. So we will be predicting based on what everyone is scheduled for Friday and Saturday for the next payroll. And please remember to clock in and out for your shifts. And then any corrections will be made on the next payroll. So if you're overpaid or underpaid, those corrections will be adjusted next time. Does anyone have any questions about that?
Thanks, Amy.
Perfect.
Okay. Next one, and Mike, jump in if you want to. We have some price increases that have to happen in both provinces to keep us alive and well. So from 10 p.m. till 8 a.m., we're now going up to 135, and the PPH combo calls. As you know, we've been up to this point, we've been taking a loss on those, offering the clients the discounts that we have because we pay full price for PPH. We are no longer going to be doing that. It doesn't make sense for us at this time. So we're going to just go to 195 instead of the 171. So that means the add-ons are going to change. I'll let Mike speak to that. But just for you to be aware that we need to quote those appropriately. And when, Mike, did we settle on a start date for that?
No, so we're going to communicate that out to everyone. The PPH, we'll communicate both. They're probably both going to happen separately. The only reason is that the PPH one, we don't need to communicate to hospitals. That's sort of like an internal pricing thing, but the consultation price increase from 10 to 8, that's something that we need to communicate to all of our hospitals first. So that's going to take some time. But so it's not immediate. We will have Sarah will probably have two communications coming out about them. Yeah,
Yeah,
you'll also, sorry, if I can just add to that, you'll also see in the portal, right? Like it'll, you guys won't, someone on the team will be dedicated to switching the price, but for the vast majority of you, you'll just see the price there. So just when you go to choose the service, just look at the service price, and you'll be, yeah, yes, sir. The eyes are, because it's probably going to be you, at least at the end of your shift for Ontario.
does anyone have any questions, concerns about that? Perfect.
This one's me. I did send out a communication in Slack, but I just kind of wanted to just reiterate this because it has happened a couple times recently. So, the RVT line is only a year and a half old. So before that, our hospitals in rural areas, they organize their own on-call. Maybe this was a pager, maybe this was a veterinarian, just leaving their cell number or forwarding lines, answering service. There's a million different ways to do this. But now that we are here, we still don't work with every clinic in the province. So there are still going to be clinics in some of these rural areas that do offer their own on call. So the best practices for these clinics, helping these clinics out to make sure their clients get the after hours services that they require and have access to, is if a client calls through the RVT line, and let's say they call a hospital that works with us, but that's not their regular hospital, we should ask them, hey, did you happen to try calling your RDVM first? Because many times some of these clinics have their own after hours operations. Just because they don't work with us, there's no way for us to give them an on-call calendar. Okay, because I know some RVTs have asked, well, can we mark them that they have on-call? We really can't because we don't control their on-call. So the best practice would be, if by some chance it's not a clinic that works with us, just confirm that they called their clinic before. Any of you that have been doing day shifts, we should be doing that regardless. It's okay, Holly, you're not the only one. I've done it in the past too. Um, we want to make sure that those clients are going to their RDVM first. Remember, we're to bridge that gap when that care cannot be given. So we're trying to help these clinics out. As I find them, I will make notes. That's that little screenshot there, the RVT notes that says offers on call. So if you do scroll down when you look at a hospital, just check for that first.
It's
And
okay.
then, yeah, that's really the best thing that we can do for them. Okay.
Yeah, and just note that in the map, some of those hospitals will default to saying no on call if we just are not familiar with their situation. So don't take that at face value. That doesn't necessarily mean there's no on call, and that's an easy mistake to make. But to just be aware of that. I just wanted to touch on Safe Pet Ontario because I know we had 2 Safe Pet calls yesterday. We've been actually partnered with Safe Pet for, oh gosh, since we started our virtual vet support service. We don't get a ton of calls for them, but I just wanted to make sure everyone's familiar with Safe Pet Ontario. It used to be a program run by under OVMA, and it's now more independent, but it's a registered charity that's devoted to assisting people who are fleeing domestic abuse and human trafficking situations, who have pets that could be at risk. So typically, people will flee with their children, but the problem is pets that are left behind. Oftentimes, abusers will threaten to injure the pets, or the people who are fleeing the abuse will be worried for their pets' well-being, and so it may be something that keeps them in a dangerous situation. So Safe Pet was created many years ago. I think it's been around since before I graduated, and I'm pretty old. So it's been around for a long time, and essentially people can apply to have their pets, and vet clinics also can apply to have clients' pets in those situations looked after in foster care. Fosters look after those animals until such time as they can safely be returned back to their owners. And the charity also helps to provide veterinary care for those pets. So what we've been doing since the beginning is offering free consultations with no script fees to any pet that's in foster care with Safe Pet. The foster just reaches out to me via text, and then I reach out to one of you lovely RVTs who's on at that time, and you can reach out then to the foster whose phone number I'll give you. Obviously, everything in terms of the actual owner's information is kept confidential. That's not released to you. The fosters do have permission to provide basic veterinary care. The costs of any prescriptions are covered by the organization. And then, as I said, we provide our services completely free of charge. So I believe the coupon code that you use is just SAFE, right, Mike?
I can confirm it. I'll put it in the chat for
I'm
everybody.
pretty sure that it is.
Safe one I use.
Yeah, but I mean, these these have often come in during the day, but we did have one during the day yesterday and then one in the evening. And I realized as I was in spot that there were a number of people who weren't familiar with what Safe Pet was and what we were doing. So just wanted to make you aware of that awesome program and that we're helping out with that. Anybody have any questions on that? It is safe, the code. Okay, good. Yeah, that's a good point, Sarah. So yeah, you'll always, in that case, receive a message directly from me with the information for the foster. And then you reach out and you book it under the foster's name. Again, you won't have the client information. And then you'll always also book those with a salaried DVM. Our salaried DVMs, I was going to say they're all up to speed, but I actually noticed in Spot last night, a couple of them weren't familiar. So I think they came on maybe after we'd started this. So I'll make sure they're all up to speed with it, but it should always be with a salaried vet. Thanks, guys.
All right, I'll take this one. This is the new hospital that Mike was speaking about. I believe it's pronounced Haida Mike, did
Hi, Guai.
Haida Gwaii, yeah.
you-
I'll actually share my screen too at the same time while you chat, Amanda.
Perfect. I just wanted to make sure that you had clarified that with them in the 2 minutes that I missed. So they are joining us on the 7th, so that is Sunday. They are the only clinic on this island. So it's Graham Island. They are the only clinic. As far as I know, it's been that way for a very, very long time. And that clients are very, very used to how things work there. So it's nothing new for them. They were using a different service before us. So not a huge change, except we're actually giving them more access to care, in my opinion, anyway. So this clinic does not offer 100% on-call services after hours. So when they are closed, the only service they provide is euthanasias for their clients. Otherwise, their clients will have to wait until the next day for care or, of course, virtual consultation. More context to this, to actually go to, well, the next closest clinics are either an 8-hour ferry ride away in Prince Rupert or a 2-hour flight to Vancouver. And again, this has been the ongoing thing for this area for a long time. It sounds like they don't even have very much human health care there as well. So it sounds like it's an accepted thing in the area. They do offer large animal. There's a good chance we probably won't be getting large animal calls, but if we do, we will be directing those to just call back in the morning when the clinic is open. All this information will be made available or is already available in their notice board. But again, they do not start until the 7th. They will have an on-call calendar, but please know that the on-call calendar is basically just there so you're able to see that they do offer euthanasias after hours, but it is only euthanasias. We put that in there as well so you're able to see the fees as well, so we can provide those to the clients. And then Sharon, I didn't know if you had anything else to add or if anybody has any questions. Mike, please
Yeah.
add anything that I missed.
No, I would just like to add, I just added this piece on the bottom that if a client calls after hours, would normally be, hold on, sorry, I don't know where that feedback's coming from. If a client calls with a patient, that would normally be a direct transfer. But you obviously, all they're offering is euthanasia, but you're not sure if it's not being requested and you're not convinced that it's warranted, please book those with DVM. So even if it would fall under those direct transfer criteria and it's after, so I should clarify here as well. I had a case from this hospital, I don't know, a couple of weeks back, or from this area a couple of weeks back, and their ferry stops running also around 10 p.m. It varies a little bit day to day, but the ferry stops running at a certain point and is not available till the following day. So after that time, air transfer would be the only way. And that's the same for human care for them. They have to be airlifted off the island. The ferry will not start up for even a human who's in dire need. So they just, obviously it's not as fast either. So they airlift them. But anyway, you can book some of those more serious ones where there's not an option for moving them quickly to physical care with a DVM to see if there's anything that we can do ourselves. If, for example, it's severe respiratory distress case, And there's a good chance that animal's just going to be suffering and probably pass during the night. We may recommend euthanasia where we wouldn't normally if there was an ER within a half hour, right? So we've had to make some of those calls in Ontario before. In the Kenora area is one good example of where we've sometimes had to recommend euthanasia when we otherwise wouldn't. And there's been some situations up north like that too. So it's a different scenario for us, sure, but in some ways not that different from what we've dealt with.
I personally also comparing it to, like, we've had, I don't know how many other technicians have had, but Moose Factory is a common one in Ontario that I've seen where they have to I think they have to take a train and possibly a plane. So it's not an unheard of situation. And Moose Factory I don't even think has a vet at all. So at least there is this option. To Lindsay's question about pharmacies, I did look that up because it was something I recently thought about. From what I can see, and I will clarify this with the clinic, there are 3 pharmacies, all closed by 5, and none are open on weekends. But I will confirm this with the clinic.
Can I add something in?
Please.
When I've been chatting with veterinarians who live and work in this area in BC as they're coming onto our team, many people who live in these areas have home kits. So that's important to know. And there are other options available. So they will have things on hand that, people who live in more centralized areas would not keep on hand. So just something to keep in mind as well.
We do have a question here, Sharon, that if there's a hit by car that will likely die without treatment, can we call the vet to do a youth? How do we make sure a client knows they are not getting treatment?
Sorry, can you repeat that again?
Yeah. If we have a hit by car that will likely die without treatment, can we call the vet to do the youth? How do we make sure a client knows that they are not treating?
Yeah, I think yes, we can. If you feel, I had a client come running in yesterday with a patient that, it had arrested, and they were in their head, this patient just needed to be hospitalized and was going to go home and be fine. So I understand that sometimes the client's just not ready to wrap their head around it yet. You absolutely can if you feel that more counseling is warranted to get those clients around to the idea of the euthanasia being the best plan. Then book them a consult, please, with a DVM so that they can be visualized. I think the video really helps us to assess. Sometimes clients overreact, sometimes they underreact. So the video really helps us to assess those properly. For the few minutes that'll take, I think it's worthwhile in a lot of these cases. If the client's saying, he's not breathing or he's, in and out of consciousness, whatever, if it's very obvious this pet just needs to be euthanized, absolutely, please send them for that.
You'll just have to explain that to the client. The options that we have are limited there. If anybody's wondering why would anybody live there, I encourage you to Google image Haida Gwaii. It's beautiful, like beautiful. Even the people that we've spoken to at the hospital are just like, yeah, it's a phenomenal place to live, because obviously they have some frustrations even for their own healthcare, but it's amazing. It's really cool. Got any other questions on that? Okay, we just want to make sure that that clients are aware too that the clinic is open, like there is a hospital accessible to them. I think their previous provider maybe had not made that clear a few times, so clients would jump on the ferry the next morning to get to the closest city. But the hospital there is open during the week.
And they are willing, they're happy to see any client, even if they've never seen them before, any pet owner.
Mhm.
No, doesn't matter who they are. They're happy to see them. And Mike, do you see the question from Brandy in the chat there?
No, I don't.
Do we charge a consult fee for the critical ones that may need to be euthanized?
Let the DVM, same as it is today. We'll let the DVM just look at the tracking notes, and we can let the DVM decide at that point. I would tell clients in advance that there's a fee to speak to a vet. Yeah, there, Jenny. See, look at that. It's amazing.
Wow.
It's crazy.
Smart vet field trip.
Yeah, yeah. We all got to go visit Haida Gwaii.
Yeah.
Just hope nobody gets sick while we're there because we have to take an 8-hour ferry ride.
Yeah, I don't know about that. It's all risky. I'm too risk averse for that situation. Okay. This is me on my old soapbox again. Just we again, I just want to reiterate, guys, that we really have to make sure that we are not allowing the RVT line to become an advice line, and we need to avoid giving medical advice. And trust me, I'm going to harp on this with our DVMs as well, because I do recognize that sometimes you're being instructed to give medical advice by our DVMs, and that's not okay. If you're comfortable being the sober second thought on that, please do be that. One example is relaying back to the client whether or not something's a toxic dose. We cannot give that. That's just stuff that, and I know it sounds silly because they could look it up online or they could find it somewhere else. But CVO does not permit us to do this. So we need to establish our VCPRs before we give medical advice to clients. Totally different from regular practice. And I know I say this all the time, but regular practices, we already have established VCPRs. And so we can give that advice over the phone. Any, RVTs can, DVMs can. We're also not under as much scrutiny in a regular practice, to be quite honest, as we are when we're doing telemedicine. So just please remember that we need to get those VCPRs in place. And I will make sure that your DVM team is remembering that as well, because I know it doesn't always come from you guys, but you guys are the ones relaying the message. So just don't want to harp on it any further, but there we go. Any questions, concerns about that? Yeah, Sean, I think that's perfectly fine. That's just practical, right? I think that's totally. I know it's a fine line, right? But I don't think that individual probably needed a medical consult. So totally okay there. This is meant to be for medical advice that is specific to that patient, that we cannot do.
I'd like to, so if I can just piggyback on that last slide just really quickly, I'm not going to talk about the medical side of things, but I just wanted to add that we have, and we've addressed this before, it's just I think it's important to bring it up, even especially for those that are newer. When we're taking calls and we're writing our call notes, what we want to have in our call notes is basically distilling the basic facts that you needed in order to make a decision. And try to keep that focus in your mind when you're taking your call notes is, what do I need to know in order to make a decision? Anything beyond that, you don't need to go. You don't need to go there. You're going to book them with a virtual vet, or you're going to transfer. So I know a lot, and it's easy, and it makes sense to think, well, if I take the history and what have you, it's going to, the vet taking the case next will be very happy about that. Ultimately, yes, they may be, but the veterinarian is likely going to go through all of that information anyways, just because they need to do their own diligence to make sure that that information is accurate. And what that results in for the client is that they're repeating a lot of information. So what I'm getting at is we don't want to ask questions that maybe are getting into sort of medical background that aren't important for you making a decision in triaging that case. We did recently get a client concern submitted to us saying that they felt that speaking to the RVT, then speaking to the vet was a repetitive process, and they just wanted to kind of get through to the next stage. So it's one, important so the client doesn't feel that they're repeating themselves, but two, it's also important for our RVT efficiency. We are an emergency urgent care line, and so let's try to keep it to what we really need to distill in the call and go from there.
I agree. I think one of the other kind of psychological things it can create when someone has to repeat themselves, and you've probably experienced this in customer care situations on the receiving end before, when you have to repeat yourself, it kind of feels like the team doesn't have it together. The communication's breaking down somewhere, and that creates a bit of a concern, right, about the credibility of the service. So just, we'll try and limit that as much as we can. Yeah, or that we're not listening. Yeah.
Just keep it simple.
Yeah. Great. Okay, and again, direct transfers, and again, this is going to be something that we talk about quite a lot, but we have chosen and adjusted our direct transfer criteria over time. We actually very recently made another adjustment to our direct transfer criteria, and we're focusing on scenarios that really do require prompt. Like it's what we're looking at is a critical need for immediate physical care. Like this pet is in dire straits. If the case doesn't fall into one of these criteria and the patient's not at imminent risk of death, then starting with telemedicine is completely appropriate. And again, that's a starting point. We're not saying when we don't directly transfer that this patient does not require physical care at some point today. We're saying it's not at risk of imminently worsening or passing away. So obviously the 3 possible outcomes are monitoring at home by the client, medication or further treatment instructions provided by our telemedicine DVM, or DVM recommends transfer for physical care. So this is after a consultation has happened. You need to remind yourselves, as I see this happening in SPOT too, that if you end up booking a consult and the patient requires a transfer, that doesn't mean you failed. It's actually quite the opposite. We have these gray area cases. If it's not immediately obvious based on the history you're taking, and remember, you're working kind of blind, right? Like, you're not seeing this patient. There's going to be a big gray bucket of patients where we're sort of like, okay, needs something for sure. We're going to book a consult. We're not exactly sure if this needs to go for direct transfer or not today. It is, if you're following the transfer criteria and you book that consult and the patient ends up being transferred anyway, you've done your job. You've succeeded. You've got care for that patient, and you need to just remind yourselves of that. We need to get our full picture. And in a lot of cases, what we read and what we see when we actually see the patient on video can be very different things. And that's because the clients have difficulty sometimes understanding what they're looking at or being able to relay it appropriately. So, and you'll see that in the sample cases we bring up in a minute. Just remember the comparison that Kristen made the last time, which I like, is the gold standard for radiographs is 2 views, sometimes even 3. And the second view is sometimes needed. And that's us assessing over video in most cases. So, yeah. And I know, Lindsay, it's, we don't like owners to be frustrated that they've paid us and now have to pay again to be seen in person. Obviously, our premium clinics, we do have our transfer discount for those hospitals that remains in place. I understand the concern there. I think what we again need to be relaying to clients is that on balance, 75% of the time that they call us, they're going to be saving money by calling us, right? And for that small percentage of the time that they actually end up spending a little bit more because they need the extra assessment, again, overall, over, say, the next 10, 15 years, the lifetime of their pet, they're going to save money by relying on us. Dana, thank you for that. Yes, I 100% agree with you. If anyone has examples of some of these, I would love to see them. And you don't need to mention names or anything, but just examples of the cases and the medical scenarios is what I'm referring to. If you can email them to me, I would love to see them, just so that I can, similarly to what we're going to be doing when we go through these case examples, we can do the same thing with our DVM team. I think that would be really helpful for them to understand. And I do understand sometimes it's that they're feeling overwhelmed also, overburdened with cases, and they're concerned about wait times. But we have to make sure that the expectations are clear. Yes, Dana, absolutely, we'll discuss that. Krista, if you could make notes of these things to Dana. DVMs, please don't cancel the consults either. What do you mean, Shauna? Like, are they going in and canceling them, or they're asking you to cancel them? Oh, I see. Yeah, no, absolutely. They shouldn't. Sorry, I'm reading out of the chat if you guys are wondering why I'm disjointed here. Yeah, okay. We had a recent one that just canceled the case. Okay, yeah, no, that's not good. Okay, thank you. We'll make sure that that communication is clear. Thanks, guys.
Amanda, can you just take a look at your messages for me, please? Thank you.
Okay. Mike, do you want to start with this, or do you want me to tackle it?
Go for it. I just had to answer a call. I'm going to jump off for a quick second, but I'll be right back.
Okay. And this is I'm just going to touch on this briefly because it's going to take us some time to work out. But I want to mention that we are looking at, as we always have, we've always kind of been able to track stats on booking percentages and also direct transfers, which I'm referring to as triage confidence here. And I know it's not just that, there are multiple factors, but we are looking at those numbers, and we are going to be reaching out to We're looking at kind of averages and where people are sitting. And we're going to be reaching out to offer, it's going to be group sessions, retraining opportunities that will be offered to you. And I can't give you an exact timeline. It's something we just sort of started working on. But there will be two different types of sessions. One for sort of booking percentages and how to confidently book those consults. I hate to use kind of sales terms as kind of like closing the sale. I don't like that at all, to think of it that way, but how are we going to instill confidence, build rapport and trust with that client, and make sure that they get their pet the care that it needs? And rather than them saying, you know what, no, I'll call back later or something like that. And then potentially that pet starts to go downhill. So working on booking percentage, and then also confidence with the triage protocols, triage criteria, and whatever else we need to talk about with respect to direct transfers. And again, I recognize also that our DVM team has a role to play there, and we're going to be addressing that. But those opportunities are going to be offered to you. We're going to be sending out emails at some point offering, well, anyone can participate, but we're going to be strongly encouraging and those of you who maybe need a little bit more retraining in those areas to attend. So just wanted you to be aware of that, and happy to answer any questions around that as well. Okay. All right. Let me go to the next slide, Sarah. Perfect. Thank you. So before we talk about this slide, I do want to introduce you, and she's here in the room with us right now, Dr. Krista Keene. She's our new, her title currently is Administrative Director, but we're going to find her a more medical title as we go through. We just kind of threw a title at her temporarily. But Krista, if you don't mind introducing yourself, and then if you want to tackle this slide, you can, or I can. It's up to you.
Well, thank you, Sharon. First, can I ask if everyone can hear me? Because I'm using one of these fancy headsets for the first time.
We can hear you.
Okay, fantastic. So my name is Krista Keene, and I am a graduate from OVC in 2006. And I've worked as a small animal veterinarian since then, and at one point actually as an associate for Sharon. And recently kind of was brought on, like Sharon had said, in more an administrative role, but also, as Sharon had mentioned, I'm around for like quick medical questions and things like that. If you're swamped, I kind of hang around and creep on everybody in spot a little bit as well. So Sharon, I'm happy to talk about this, or you can. It doesn't matter to me.
Yeah. So just for clarity there, if you see Krista in Spot, and Krista, do you have DVM behind your name in Spot?
No, I don't. I just have Krista and then in brackets you.
Okay. Yeah, no, that's fine. So I think what we want to make clear is Krista's not going to be seeing consults, but she's certainly there in Spot to, if RBT team has anything that you'd like to address with Krista in terms of medical decisions, that kind of thing. Krista could also, she's licensed in Ontario, not in British Columbia, but licensed in Ontario. So if we need to make a quick change to a script or something like that, you can certainly reach out to her. She's there during the days. So, well, and sometimes in the evening, as like right now. So feel free to do that and reach out. And you'll also be receiving communications from Krista as well as myself when it comes to some of the medical things. So I'm really excited to have you on board, Krista, and welcome.
Thank you so much. I'm really excited to be here. This is all very, very cool.
So Krista has been in charge of, so as you know, on the months where we have 5 Wednesdays, we have a full team. We just implemented this when we recently had Docs for Grade 8 speak to us. We have another one between now and I think August is this one, right?
Yes.
So we will in August have a guest speaker on the 5th Wednesday of the month at 7 p.m. And we just know from, just some of the cases that are on the RBT side and on the DVM side are tough to manage remotely. We do get a number of these sort of gestation, labor, delivery, and neonatal care questions coming through, or cases coming through. Our DVM team and you guys as RBTs likely have a ton of burning questions that you'd like answered. And so we do just want to give our guest speaker a little bit of a heads up as to some of the main things we'd like to have answered. There will also be, I think, Krista, a Q&A at the end of his talk, right?
I would imagine so. He seemed pretty flexible on what we wanted to discuss. So yeah, I think if we came with already some questions that we have, and then just kind of go from there, he'd be super happy with that.
Yeah. So if you guys want to put, if you have some that you already have at the top of your mind, want to throw them in the chat, and Krista can take notes, or feel free to email them to KristaK@smart.vet, and she'll make sure they get to the right person. But some of those common scenarios, I guess, and how to best manage those. And we'll also ask the DVMs the same.
I was going to ask what Don's asking.
That would be an Amy question. Amy, are you here? I don't know if Amy's here. We would need to, oh, go
I'm
ahead.
here. I think that we probably have time to make that happen, Sharon.
Okay.
Yeah.
Okay.
I'll make myself a note.
I think this would be a great one to have as many people attend as possible, because, sometimes we're all kind of madly searching on VIN when we're faced with these scenarios or whatever. So I think it could be really great. Yeah. So by all means, send those questions over to Krista, or even just scenarios and what do I do if, or throw them in the chat here.
Sorry, guys, I just took a large animal line call because there was nobody on the line. I might have missed something. Sharon, did you just talk about the booking percent in triage
I
already?
did. You may want to add something. I'm not sure.
Well, I'm not sure what was said, so I don't know what I'm adding to. But I just the one thing that I want to mention is, we are looking at stats, and I think we've mentioned this before too. We have more data and what have you now too. So I just want to highlight that one important thing too is efficiency on the phones and number of calls in an hour that are taken. So we'll be communicating that out to the team. And again, we're always looking at averages, like what are people averaging, and then how are people comparing against that average. So just want to highlight that. And so it kind of ties back to earlier efficiency with note taking as well, and just making sure that A, we're being effective when we're on the phone, and then B, in our after call wrap up, that we're kind of working through that as quick as we can, and becoming available for the next call. Cool. That's it.
Thank you. I guess we're at case reviews. Oh, sorry. I was totally in the wrong screen. I'm sorry, guys. Okay. So again, we're just going to go through a couple of case reviews. This is really fascinating. Actually, I really like these ones. Thank you, Sarah, or whoever put these in here. So this one, 5-month-old female intact Great Dane with vomiting and diarrhea, continual diarrhea. I suppose there was vomit when the owner came home, but there hasn't been anything further. No blood in the vomit. Was recently treated for Giardia, has finished treatment, and bowel movements had improved on meds. And owner has said the mucous membranes are pale, which, as you all know, is a direct transfer criteria. So you check that box and that patient should be directly transferred. But this brilliant RVT requested a photo of the mucous membranes. Let's see how they look. What do y'all think? Are those pale?
They're
Yes.
pretty. Some pretty gums.
I think, Michael.
Nice and pretty pink.
Yeah, those aren't really pale mucous membranes. So a consult was the right way to go. And again, it just goes to show how important these visual cues can be. And this was really perfect decision to book this patient for a consultation.
I wonder, did we ask the owner how he cut his finger?
I know the Band-Aid looked a little dirty to me. I don't know.
The owners were very distraught cleaning up diarrhea from all the walls of their living room. I did not ask.
To be fair, it would be pretty distressing to come home and find your Great Dane had diarrhea and vomited all over.
They were so nice. I felt so bad for them.
I'm sure Jenny knows what that might be like, maybe.
True. Okay, so now we have a 7-month-old female spayed domestic, medium hair, not eating, not drinking, lethargic, vomiting, and drooling. This owner also says mucous membranes are pale, had some diarrhea on her bum today, was spayed 10 days ago. She's just a baby. Was outdoors unsupervised yesterday, no obvious toxin exposure. Let's see those mucous membranes. What do y'all think of these? These look a little cyanotic. Yes, Jennifer. Oh, no. Not good. We need to transfer this patient. So I think this really does go to show how important it is for us to visualize these things. So as often as you can, send the clients that link to upload or to send your get them to send you a photo so that we can have some backup for this decision making. I think it is really important, and in this case, potentially, I don't know what the outcome was for this patient. Does anyone know? Was euthanized.
Yeah, sorry, I typed in the chat. I texted her later, and she said it was possibly Pan-Luc, but she was very thankful that we were able to get her seen so quickly so she didn't suffer.
Yeah, no, exactly. And I mean, in some cases, this could have led to saving a life, right? Just being able to know to not put this one in the queue for telemedicine based on this appearance. So yeah, great call. Sad case. Okay. Who's in charge of this one?
Amy.
Amy.
Oh, she shared her screen. There she is.
I was
Sorry.
gonna say, so you're not gonna give us your drum roll and
I have a cold and I'm coughing, and so I'm muting and unmuting and trying to be lovely. Okay, we had 26 entries this month, and we'll shuffle them up. And you guys, now I know that you can't hear the little spinny wheel that it makes, which makes me so sad. It makes such a great sound. Okay, so drum roll, and the wheel is spinning.
you can make a nasally spinning wheel
A,
noise.
a nasally spinning wheel.
Poor Amy. The kid's constantly getting her sick.
Is that, who is that?
Sarah for sure.
Okay.
No, it's
That's
Jenny.
Jenny.
That sounds like
It's
Jenny.
me.
It sounds like Jenny. You
I
can tell.
was channeling Tina from Bob's Burgers.
Bridget, you're the winner.
Congrats.
Congratulations. How painful for you to win while they were making nasal sounds. Uh, awesome, Bridget. I'll reach out.
Congrats, Bridget.
Oh my
Okay.
gosh, did we make it to questions within time this
I
week?
can't believe it.
Well, Sarah forgot a
Congratulations.
slide, so
Oh yeah, there's one more slide. It's just quick. It's just quick. No, it's just that. So just want to announce to everybody that PetSmart is going to be launching their pilot with us as of May 15th. So we oh, thanks, Jenny. We did have a session about it. Sarah put out an SOP about it. I will be putting out an additional little quick video. Haven't done one of those in a long time, so you'll see another video about it as well. It mostly applies for people that are on during the day, during weekdays. However, for those of you on the weekends, you'll also see those cases come in. Amy, can you speak to Exotic Vets and what we're doing there just to help out? Sorry, I know you're probably hating me right now for putting you on the spot.
No, so I've been targeting veterinarians in Ontario specifically who will see exotics. We have onboarded a few more, and there will be more coming. Prior to the 15th, we'll put out a list as well for everyone, just with what species they see, as well as a list so that you guys are a little bit more aware. And we have in the next couple of weeks, we have a few fairly connected people in the Ontario area, one from Campus Estates and one from a practice in Toronto, who both see exotics who are going to join the team as well.
Just a reminder, this is not pet owners. This is staff of the stores that are reaching out for consults during shift. So they'll be trained on a process internally. These calls should be pretty quick. You're doing your triage assessment, and payment details is already on the file, and a bunch of other information is already there. So pretty quick for you guys.
Oh, thanks, Francis.
Yeah, that's awesome.
Yeah.
One day when we're in Quebec, Francis, tu vas nous aider en Québec aussi.
That's great. Good. So are we Does anyone have anything, questions, comments, stories, anything you want to chat about before we let everyone go? It can be related or unrelated to the
Not
things
used to being done this early. What do we do with ourselves?
I know.
I was trying to find the picture of Louise dressed up as Louise for Halloween, and I can't.
Oh, Jenny.
So yes, that's what she's named after. She likes bums, just like Tina.
Wait, what? For anybody who doesn't know this, is Tina? Who's Tina?
Tina's the sister, and then Louise is the psychopath younger one that has the bunny ears.
Yeah, but
She likes bums.
bums.
Well, Tina does. Yeah, she's obsessed. She does her what is it? Her
Erotic fan fiction.
erotic friend fiction, though. She has her friends in it.
Do you guys suggest watching Bob's Burgers? Is it
It's fantastic.
amazing?
I relate to every single one of those characters, but I might mostly be Alinda.
You are 100% Linda. 100%.
Yeah, she's a cheerleader too.
I read Shauna's message as something completely different there for a sec.
Yeah, so did I. I saw it.
Yeah, same, Mike.
Get HR in here.
Good. Maybe next meeting we'll just watch an episode of Bob's Burgers for the hour.
Yes, I'll pick the one.
Yeah.
It's got to be the one where the sister does the arts, where it's all the pet butts.
That'd actually be fun. We should totally do that. Just like a session where everybody just sits here and watch it. We can have it streaming on one person's screen. That'd be great.
Yeah.
I like it.
It's the art exhibit episode in the first season.
We should totally do that.
Yeah, the buttholes. The window of the soul.
I just want to watch it now to get more insight into Jenny.
Oh, that's hilarious. It's not safe to get too close, so
Makes you tick.
yeah. Amy's like, oh dear. Yeah, we have a lot in common.
Brandy wants to get out. Anybody who wants to head out, you can. If there's no more questions, I don't want to hold people hostage. Good night, everybody. Got a good episode of Bob's Burgers in if you can.
Yes, it's good for the
Guys.
soul.
I'm going to hang out for a couple minutes in case anyone has any